Bismillah ar-Rahman ar-Rahim. Today's topic of discussion is Wernicke and encephalopathy and Korsakoff syndrome. I think it is a very huge, very big topic. So we might have to try to split it in two parts depending on the time. So maybe today we will do the Wernicke's encephalopathy only. And in the next session, inshallah, next Saturday, we'll do then the Korsakoff syndrome. So that's how we are planning for the time being. Uh, so what is encephalopathy? Anyone who wants to define the encephalopathy or encephalopathy? Anyone?
Yes, it basically involves the injury to the brain mass or tissue as a whole. There is a diffuse.
Hmm. Hmm. Yeah.
It's acute change in the function of the brain due to any acute insult or damage to the brain.
Yeah. You're right. Yeah. So basically, encephalopathy is the cause and delirium is the result. Delirium syndrome and encephalopathy is the disease, which is syndrome. For example, diabetes is a syndrome, but the disease is usually somewhere in in pancreas. So similarly, alcoholic liver disease, the syndrome, the symptoms are the syndrome, but the cause could be hepatitis B, alcoholic liver disease, or hepatitis C. So similarly, encephalopathy or encephalopathy is a cause for the delirium or the delirium syndrome. So basically, we will be dealing with the delirium picture today uh, in Wernicke's encephalopathy. It is a delirium for which there is a known cause. So Wernicke-Korsakoff syndrome, Wernicke's encephalopathy is the delirium part of this, and then the other part, which is the cognitive impairment part, is called Korsakoff syndrome. So that specific cognitive impairment as a result of Wernicke's encephalopathy, that is called Korsakoff syndrome. So Korsakoff is a bit similar to, not the same as, it is similar to dementia, and encephalopathy is delirium in itself. Korsakoff is very, very, very mild cognitive impairment. It is not dementia, but it is just amnesia. So, which is one of the symptoms seen in dementia, just one symptom, and that is Korsakoff syndrome. So, alcohol-induced delirium. So, alcohol-induced delirium means that alcohol can cause delirium in when it is kind of intoxication in itself can cause delirium. So intoxicated, drunk people, and sometimes them in our day-to-day life, sometimes uh, one-to-one, sometimes on media, some person appears as drunk, and they are a bit excited, and it is possible that they are delirious. So intoxication in itself can cause delirium. Then is alcohol withdrawal delirium. So alcohol withdrawal should not generally it does not cause delirium. It causes restlessness, anxiety. That is the psychiatric symptom of the alcohol withdrawal. But sometimes it can cause delirium, and that is delirium tremens. अब वहां पे उसको ट्रीट करना बहुत जरूरी हो जाता है कि अगर आप ट्रीट नहीं करेंगे, यहाँ पे जो डिलीरियम ट्रेमेंस है उसमें न्यूरोलॉजिकल सिम्टम्स इतने ज्यादा नहीं हैं. देयर आर नॉट मैनी न्यूरोलॉजिकल सिम्टम्स, बट वंस यू ट्रीट द डिलीरियम tremens, it's very important. Otherwise, it may progress to Wernicke's encephalopathy, which is delirium with defined specific neurological symptoms. And Wernicke's can lead to Korsakoff Syndrome, which is largely irreversible cognitive impairment. That's why it is so important to treat the withdrawals, even if they are without the delirium, treat them. और अगर delirium हो गया है, so it's more important to treat them. And if it is Wernicke's encephalopathy, you must treat those withdrawal. Otherwise, may go to Korsakoff syndrome. Wernicke's encephalopathy. So it is an acute neuropsychiatric syndrome. Means कि neurological भी है, psychiatric भी है. And so neurological signs will be, first of all, when the patient has gone to confusion, it will be nystagmus. Then it will be ophthalmoplegia, especially the abducens nerve ophthalmoplegia, sixth nerve. Could be total, but usually it is abducens nerve which is most involved. So these are two neurological. Then the third, let's go neurological first. So the ataxia, that's also a neurological. So the three symptoms are neurological so far. Nystagmus and ophthalmoplegia, sometimes people combine that as an ocular symptoms. And then they say it's a triad. And but we can separate the two. So nystagmus, ophthalmoplegia related to eye. Then the third is ataxia, unsteadiness of stance and gait. यानी जब वो खड़ा होगा तब भी imbalanced होगा. You can do the Romberg sign to check the ataxia. And when you are asking them to walk, then again they will be, इसको कहते हैं कि लड़खड़ा के चल रहा होगा. The ataxia will be very much profound in walking as well, both standing and walking. And that's why if they give you any OSCE station, cask station, which may come as and like Wernicke's encephalopathy, so you need to check for alcohol withdrawal, like pulse, blood pressure, sweating, anxiety, restlessness. And then you need to check for nystagmus and ophthalmoplegia. So you need to check do the eye examination. Then you need to check the Romberg's test. Then you need to check the normal gait, whether it's normal or not. Then you may, with the support, gait जब भी आपने check करनी है, you need to provide support to the person. When you are providing the support, then you can check for the tandem gait, heel to toe fashion. Okay, you have to walk in a heel to toe fashion, so in a straight line. तरह एक लाइन लगा के उसके ऊपर पांव आगे पीछे करके चलना है आपने, बिल्कुल एक स्ट्रेट लाइन में. तो जो दायां पांव है, the right foot will come just in front of the left, and then you will alternate the feet, straight line. So that's what you can check for the ataxia while you're doing the examination. But the patient is ataxic, so you need to support the patient. In any ataxia Romberg's examination, you need to support the patient. Otherwise, you will fail your station. the patient may fall. And then the fourth thing is mental state changes, which is delirium. So delirium में क्या होता है, lack of attention and concentration, hallucinations, and especially in delirium tremens, you see the Lilliputian hallucination, which is kind of seeing small soldiers or small men walking on the table or walking on big surfaces, very small creatures. That's what they see in delirium tremens. Hallucinations, disorientation, clouding of consciousness, and some memory impairment in the transient. So that is all. These are all the mental state changes related to delirium. So you are seeing the delirium tremens. In addition, you are seeing the nystagmus, ophthalmoplegia, and ataxia, and that combination of four symptoms, or if you say nystagmus and ophthalmoplegia as one, then three symptoms. This triad is called Wernicke encephalopathy. Now, this complete pattern is seen only in 16% of patients. So, हर मरीज में हर चीज नहीं आती. Some patients may get some symptoms and some may get other, but only 16% will get this classic tetrad of nystagmus, ophthalmoplegia, uh, delirium, and ataxia. And now the pathophysiology, it results from a deficiency in vitamin B1, which is thiamine, which is in biologically active form, thiamine uh, pyrophosphate. So it is thiamine pyrophosphate, the biological active form of vitamin B1 or thiamine. It is an essential coenzyme in several biochemical pathways of the brain. Any delirium is a medical emergency. Alcohol withdrawal in itself is a medical emergency, but of severity as compared to delirium tremens. So delirium tremens is a major medical emergency. Wernicke's encephalopathy will be even of a higher rank, more severe medical emergency as compared to delirium tremens because of the neurological symptoms. And in suspected cases, not even in confirmed, in suspected cases, thiamine should be initiated immediately, either intravenously or intramuscularly, to ensure adequate absorption. जैसे ही alcohol withdrawal शुरू होता है, as soon as the alcohol withdrawal starts, you start giving thiamine. Because if you don't give, then it may become delirium tremens, or it may go into Wernicke's encephalopathy. And then Wernicke's can go to Korsakoff syndrome, which is an amnesic syndrome. So it is potentially irreversible, not always, not 100% irreversible. I've seen patients regaining some function from Korsakoff syndrome, but it is rare. Usually it is irreversible. So retrograde and anterograde amnesia, inability to assimilate new information with varying degrees of other cognitive deficits. Now, the etiology of Wernicke's Korsakoff syndrome. So the first thing is deficiency in thiamine, which is kind of thiamine pyrophosphate in its active form. It's a coenzyme. That's one thing. So primary thiamine, basically क्या हो रहा है, thiamine deficient हो रहा है. If someone is coming with Wernicke's encephalopathy, will you blame them for alcohol or not? Anyone? Unmute yourself and tell. Will you, if a patient comes with Wernicke's encephalopathy, will you will you just say, will you blame that it is it is were you drinking alcohol? Will you straight away blame or not?
नो सर, अदर कंडीशन में भी हो सकता है, इसलिए केवल अल्कोहल को ब्लेम नहीं कर सकते।
Exactly. Alcohol is the leading
severe
cause,
dehydration.
but it is not the only cause. There are other causes for this. The main cause is thiamine deficiency, and the cause for the vitamin like thiamine deficiency, the leading cause may be alcohol. So it could be from generalized malnutrition. So let's say if a person is malnutrition, or let's say if a schizophrenic man is living in the slums and not eating and drinking for many months, he may go into Wernicke's encephalopathy. And alcohol is one. Then anorexia nervosa, they are also at risk of any deficiency, and that may include the uh, Wernicke's encephalopathy, then AIDS, HIV. Hyperemesis gravidarum means that in the pregnancy, when the women have they vomit again and again, so they may lose their electrolyte imbalance. Plus, it can also result in vitamin deficiencies, thyrotoxicosis due to some reason, metastatic cancer, that can also cause that, hypomagnesemia, long-term dialysis, congestive cardiac failure, and treatment with diuretics. So all these can, and also bariatric surgery. The patient I saw, he was alcoholic plus he had bariatric surgery. So the thiamine is not being absorbed after the bariatric surgery. So and then they so that's the post bariatric surgery. They have a limited capacity for food intake during the initial weeks, so you have to give them supplements, otherwise they will inevitably uh, uh, get the Wernicke's encephalopathy, and they may be a kind of teetotal or pioneer. These are the terms कि जिसने कभी अल्कोहल यूज ना की हो या जो सिर्फ चाय पीता हो, that is teetotal. Pioneer means जिसने जिंदगी में कभी अल्कोहल ना इस्तेमाल की हो, as we see in practicing Muslims. तो उसमें जो है वो once even post bariatric surgery, टोटली नॉन अल्कोहलिक पीपल में भी ये डेवलप हो सकती है, बट यूजुअली इट डजंट हैपन, क्योंकि जो भी बेरियाट्रिक सर्जरी करेगा, जो अच्छा सर्जन होगा, वो डाइटिशियन को इन्वॉल्व करेगा, वो सप्लीमेंट्स भी देगा. And also, paradoxically, sometimes post bariatric surgery patient may still remain obese. And obese people में ये बात याद रखिएगा कि कोई भी deficiency हो, especially vitamin D3 deficiency, उसके chances ज़्यादा होते हैं. So obesity is a risk factor for vitamin deficiencies in itself. अब एक बंदा है जिसने bariatric surgery भी करवा ली है, तो उसका स्टमक भी नहीं रहा, ऊपर से जो ओबेसिटी की वजह से उसकी एब्जॉर्प्शन वैसे ही स्लो है, he'll be and he's still obese even after the surgery, the chances of deficiency will be more. और इसीलिए आजकल जो obesity is a risk factor for COVID. The reason is that they are the people who are mostly vitamin D deficient. we should take prophylactic vitamin D, and especially if we are overweight, we must take it to prevent ourselves from the COVID. So thiamine pyrophosphate, the active form of thiamine, uh, and it acts as a coenzyme in three enzymatic reactions, metabolism of glucose and several other neurotransmitters, including acetylcholine. अब ये जो acetylcholine है, that is related to memory. That's why in the Aricept, in donepezil, or rivastigmine exelon, or galantamine, they are all the acetylcholinesterase inhibitors. They increase the amount of acetylcholine in the brain, and that's what reverses the cognitive deficit, or at least slows down the cognitive deficit. So अब यहाँ पे ये acetylcholine को कम कर रहा है. It is reducing acetylcholine in certain brain areas, the thiamine deficiency, because thiamine is essential for acetylcholine, and when it is not there, then acetylcholine will not be there. And which medications can cause cognitive impairment related to acetylcholine? Anybody unmute and answer that?
Anticholinergics.
Exactly, anticholinergics, and that's why, and many medications have their anticholinergic potential, but anticholinergics have the maximum anticholinergic activity. For example, procyclidine is 100% anticholinergic, but olanzapine, chlorpromazine, tricyclics, they have also anticholinergic properties, so they can affect cognition. So you need to be careful, especially with the procyclidine. So we need to we may lower the dose of antipsychotic instead of adding procyclidine. That will be the ideal thing to do. But in youngs you can use, but in elderly try not to use the procyclidine if at all possible, and reduce and use very reduced doses in elderly. बिकॉज यंग में आपको हायर डोजेस उसके सेडेटिव इफेक्ट के लिए चाहिए होती हैं, फिर आपको साथ एंटीकोलिनर्जिक भी देनी पड़ती हैं. लेकिन एल्डरली में आपको वैसे ही छोटी सी डोज के साथ आपका काम चल जाएगा. साइकोसिस, स्मॉल डोजेस इंस्टेड. तो यहाँ पे क्या है कि thiamine is causing kind of it is helping the production of acetylcholine. Numerous mechanisms have been they've lost neurons in thiamine deficiency, cerebral energy dysfunction, breakdown of blood-brain barrier. Then there is a glutamate hypothesis as well, thiamine related to the glutamate neurotransmission caused by extracellular glutamate and its impaired transport function, together with NMDA receptor mediated excitotoxicity and the accumulation of amyloid precursor like protein, increased free radical production. So these are all. One was the acetylcholine, then the glutamate pathway, and then amyloid precursor protein, and increased expression of superoxidase, of nitric oxide, and oxidative stress. So they're all the things which are mediated by thiamine. And if thiamine is not, then all neurotransmitters will not. Serotonin metabolic thiamine deficiency. जो शख्स आपके पास आया है Wernicke's encephalopathy या serotonin metabolism is also affected, and 5-hydroxyindole acetic acid 5-HIAA were reduced in CSF in patients with a now anatomical lesions in WKS. So anatomical lesions जो हैं they will be described in association with thiamine deficiency. So medial dorsal thalamic nuclei, mammillary bodies, they can be atrophied, they can be damaged. और जितना mammillary bodies का damage ज़्यादा होगा reversible हो जाएगा because it's a structural, it's a kind of visible structural damage. तो फिर the Korsakoff, and it is found in Korsakoff syndrome. And fornix, cerebellum, anterior thalamic nucleus, and then so the physical examination we have already done, the symptomatology. What I would like to emphasize here is any patient coming to you, you check for nystagmus. That is the most common effect and most common symptom. Relatively less common is the bilateral lateral rectus palsy, which is the abducens nerve palsy. And then the most common ocular abnormality is kind of that is nystagmus, then encephalopathy. So the delirium is then the next symptom. Disinterest, inattentiveness, agitation, stupor, and coma are rare manifestations of Wernicke's encephalopathy. Then the third is gait ataxia. यानी कि जब ataxia during walking, one is a truncal ataxia or standing ataxia, and one is a gait ataxia. Both can be seen, but so in the hierarchy they describe gait ataxia because there is a polyneuropathy, cerebellar damage, vestibular paresis. Due to all these things, the gait will be abnormal. So you should check the gait. You should check cognition. You should check the nystagmus. You can ask about the mood because in delirium the mood is, what is the most commonly seen mood in delirium? Anyone? What mood do you usually see in delirious patient?
Irritable?
Yeah.
Agitated?
Irritable, agitated, frightened, all these, yeah. And in this case, you know, sometimes in hypoactive delirium, you can see depressed mood as well.
Flat effect type, yeah.
Yeah. Okay. So truncal ataxia, you can see peripheral neuropathy. So it will be a good practice to check if a station comes for Wernicke's encephalopathy, not only for Korsakoff but Wernicke's. I would say that, you know, I would check for peripheral neuropathy, so I will check the sensations, the distal sensations, where one will be the sense of vibration and a sense of position with the help of tuning fork or with the moving the fingers. So I would check that in the end. But after the gait is very important. And the standing Rombergs, these things are the most important in any alcoholic person. So gastrointestinal symptoms can also be there: nausea, vomiting, abdominal pain, lactoacidosis. Now, so the physical examination, check for the alcohol withdrawal symptoms. So it is important to do the vital signs anyway, because hypothermia can be there, hypotension can be there, and then you can see the restless effect as well. And then you can also check for the symptoms of Korsakoff syndrome, usually in the latter stages when the Korsakoff has started. But as a part of delirious mental state, you can check for the memory. So you're not only checking for Korsakoff, but you are in any delirious patient, you can do the Montreal cognitive examination, not for cognition, just to assess the severity of delirium. And you can't deduct any baseline inference from that because that won't be reliable for cognition. But that will tell you that the patient is delirious. So retrograde amnesia, anterograde amnesia, decreased spontaneity, initiative, confabulation. You can check these in Wernicke's encephalopathy, but I won't go much. If the patient is confused, I would just ask one or two memory questions. I won't go into detail. But once they have come out of that confusion, then I will go for the detailed memory testing for Korsakoff. Cardiovascular symptoms, you can do the CVS examination, peripheral nervous system, as we have already said. Ask for symptoms, for example, constipation, agitation, apathy, vomiting, lack of appetite, grunting, etc., etc. Now, uh, so we have gone through the examination, and now no specific laboratory test is available for diagnosing the Wernicke's encephalopathy. But you need to check the electrolyte levels. You need to check the vitamin D3, vitamin B12, folate, because of these comorbidities. So you need to check for the comorbidity. For example, you will see macrocytosis in alcoholics due to their vitamin B12 deficiency, anemia, or otherwise you can see macrocytosis, you can see deranged LFTs, but they will not tell you anything about Wernicke's encephalopathy. They will tell you about the comorbidities. So even if all the blood tests are normal, you are seeing the Wernicke's encephalopathy, then the motto should be, if in doubt, treat. क्योंकि अगर आप thiamine दे देंगे, it won't cause any harm. So administration of thiamine will be harmless, mainly unless there is an anaphylactic or allergic reaction to thiamine or any other ingredients, which we'll come to later. So maybe do a test dose in a person who has not received thiamine injection or multivitamin injection, just to check that they are not allergic. And if they are not, then give the actual dose, just for the very first dose. And then if they tolerate the first dose, then they can be given the rest of the doses. Potential diagnosis, जैसा कि हमने पहले कहा कि alcohol withdrawal syndromes are there, delirium due to other causes, delirium tremens, alcoholic ketoacidosis, amnesia due to other causes, normal pressure hydrocephalus, cerebrovascular accident, stroke, ischemic stroke, chronic hypoxia, closed head injury, hepatic encephalopathy. Yeah, hepatic encephalopathy is a very important delirium. Sorry, differential diagnosis, and it is a delirium, but that's why it is so important to check the liver function tests. If the person's liver reserves are not there, they can have Wernicke's encephalopathy plus hepatic encephalopathy or one of them. Delirium can be due to multiple causes at the same time. Post-ictal state, psychosis. जब alcohol withdrawal में जाएगा बंदा, they can have seizures, and after the seizures they can go into delirium, and that is the importance of checking the eye symptoms, nystagmus and ophthalmoplegia. That will tell you whether it is Wernicke's or not. And then you are going to give thiamine anyway. So the rapid correction of thiamine deficiency Pebrinex 1 and 2, IM or IV. Is Pebrinex available in India, Doshadji?
I am not sure, sir, actually.
And in Pakistan, is it available? I don't think so. Okay, so
Not sure, sir.
yeah. So Pebrinex is a combination of will come to it is mainly combination of thiamine, vitamin C, and other vitamins, but it is not available in Pakistan and India. So we'll talk about the alternatives in the next slides, that what can you do instead of Pebrinex, because if you give oral thiamine, it's not going to be absorbed, because the absorption is so poor in the alcohol withdrawal state, and you need very high doses. Even if it is absorbed, it will be absorbed in very small doses. So the deep intramuscular injection or intravenous infusion, that will be ideal. By intravenous infusion, 2 to 3 pairs TDS. So there are two vials. One is kind of we'll come to the ingredients. So let's say one is thiamine plus something. The second is vitamin C plus something. So you give 2 injections in 2 different syringes. I mean, it can be, if you have an IV cannula, you can give multiple injections with one prick, one after another. So usually these patients are cannulated, or otherwise you can do the intramuscular. You can switch the syringes with the same needle and give the two injections one after another. So, but that is in the Western countries where Pebrinex is available. And I have worked to work out, find out what could be the alternative and what dose will be the alternative for Pebrinex. So one pair, like 2 injections, once daily for at least 5 days. That's for prophylaxis. But if the patient is delirious, they are in alcohol withdrawal, even withdrawal or delirium tremens, then I would give 2 to 3 pairs TDS for 3 to 5 days. Okay, then oral alternatives, especially when the course is complete, then you switch back to oral for next 1 to 2 weeks. So Orovite 1 tablet TDS plus thiamine tablet 100 milligram TDS for another couple of weeks, and then you can continue that for a long term as 100 milligrams OD. So Orovite, the reason I'm saying that Orovite plus thiamine is because Orovite में जो thiamine का content है, that is only 10 milligrams. And you need at least 100 milligrams TDS. So I would give, and many centers do the both. So at least thiamine TDS, or ideally thiamine plus Orovite, because you can get the riboflavin and pyridoxine, niacin, and vitamin C as a part of Orovite tablets. So Pebrinex, if you're working in the UK, Ireland, and US, that's the brand of multivitamin used here. So thiamine is 250 milligrams. It's not only 100, but 250 milligrams. And you're giving for the 3 to 5 days, like it's a TDS injection of both ampules together. So ampule 1 is thiamine, riboflavin is 4 milligrams, pyridoxine is 50 milligrams. The second vial, second ampule, will have the vitamin C 500 milligrams, niacin or nicotinamide 160 milligrams, and glucose 1 gram. So it contains glucose as well, because the glucose can also go into hypoglycemia. So Pebrinex takes care of that. And but if you're not using Pebrinex, just make sure that you are giving enough nutritional support via oral route, especially the glucose, and maybe vitamin C separately you're giving. Main thing is thiamine. So that is the Pebrinex, and I'm not promoting their company, but that's the only brand we know in the in the Europe and America. So and then, so which of the vitamin or nutritional substance is not included in the ingredients of Pebrinex? And
B12,
Pebrinex में इन पांचों चीजों में से कौन सी चीज नहीं पाई जाती?
B12.
B12, sir.
Yeah, P12 is not
B12.
part of Pebrinex. So you can do the B12 levels. If they are deficient, then you can treat it. But otherwise, they are not part of Pebrinex. Now we come to the Pakistan and in India part, that what we will give. Again, you can uh, mute yourself till the next question. So neurobion, which is used in or neurobidoxin. Again, there is no conflict of interest. I'm just I म्यूट कर दें काइंडली अपने आप को. हाँ तो न्यूरोबायोन और न्यूरोबिडॉक्सिन दोनों पिक्चर्स मैंने डाल दी हैं. No conflict of interest. I'm not promoting any company, but just to show that what is available in Pakistan, and maybe similar things or the same things in India as well. So this is B1, B6, B12 neurobion. So what is deficient here? Glucose is not there, and B5 I don't know, riboflavin maybe B2 or something. Riboflavin is not there. Pyridoxine may be there, and cyanocobalamin is not there, and in both. Vitamin C is not there. So B1, B6, B12. At least you are getting the desired thing, which is B1, thiamine. You can overcome the thiamine deficiency by using the neurobion or neurobidoxin. Now we will check that how much. So that least thing, at least you will need 100 milligrams TDS as a dose. So we'll see whether, because we were giving 250 milligrams TDS in form of Pebrinex. If we go here, it is 250 milligrams of thiamine. So we'll see whether are we giving the same amount in neurobion or not. So thiamine is exactly 100 milligrams. So that's fine. I mean, we don't need the full 250 as long as we are giving neurobion uh, 3 times a day. That will give 100 milligrams thiamine. Pyridoxine, which is B6, so 100 milligrams as well. These are the less important. So whatever dose they are going, that's fine. Cyanocobalamin, it's not there in the Pebrinex, but it is there in Neurobion. So in 3 ml, and there's only one vial of Neurobion. So 3 ml of aqueous solution for injection. So if you give Neurobion, if the patient is not allergic, just check the allergy test first. Give a test dose. It can also cause in pain at the injection site, so it is very painful. Just be mindful of that as well. And just give a very small dose just to test for the allergy if the patient has not received neurobion in their life before. And then you can go ahead with the 1 TDS for 3 to 5 days just to cover for the thiamine deficiencies. So neurobion, Bavidox, neurobidoxin, 1 ampule TDS IM. Bavidox, again, I'm not promoting any company, but when I checked the Bavidox, it was a little bit less of thiamine. in Bavidox, but otherwise that can also be used. So alcohol withdrawals 3 to 5 days. So 1 ampule TDS. That's what I would suggest. Because we don't have Pebrinex. If we have Pebrinex in Pakistan or India, use that. But if we don't have, then maybe you can use the neurobion. So prophylaxis maybe 1 ampule OD for 5 to 7 days. So now there are the neurobion tablets or Bavidox tablets, which are both available in Pakistan, and they are B1, B6, B12. So each regular neurobion tablet, the same thing, same amount of thiamine, which is 100 milligrams of thiamine. So you have to give at least 1 TDS in the withdrawal state for 1 to 2 weeks, and then maybe 1 OD after that as a prophylaxis. 200, and the best prophylaxis, if it is caused by alcohol, then staying away from alcohol plus getting thiamine, that will be the best prophylaxis. If you're taking alcohol, then that's not the best thing to do. So 200 milligrams of pyridoxine, 200 micrograms of B12. Bavidox, again 100 milligrams. Pyridoxine is 50 milligrams, which is a little bit less. Cyanocobalamin is 0.05 milligrams. So Bavidox is mainly thiamine. You can use any because main ingredient you want is thiamine to go in. But neurobion will be good because it has the B6 and B12 in larger quantities. So treatment, other things, chlordiazopoxide for detoxification. Alcohol, because they are very restless, so they need something to calm their brain, and chlordiazopoxide will be used. Correct fluid and electrolyte imbalance, and monitor vitals, ensure adequate nutrition, treat other comorbidities, seek opinion of neurology and medicine, especially if you're using the neurobion, instead of Pebrinex. It is in the first few cases, if you've never done that, seek the opinion of medicine and neurology. That is it safe to give that, and then use it. And if you're using every day and you know that nothing happens, then keep using it. So prognosis of Wernicke's encephalopathy, and we are nearly reaching the end of today's. So tends to reverse fairly rapidly with vitamin supplementation. जब आप delirium की stage पे जब आप उसको treat कर देंगे, तो it will be a relatively good prognosis. But if you fail to treat, then 50% of those, I don't know, treated or untreated, may progress to Korsakoff syndrome. But if you're treating it, the chances of getting Korsakoff syndrome, which is amnesia or amnesic syndrome, will be less. So Wernicke encephalopathy responds dramatically to the administration of thiamine. Even very small dose, maybe 1 milligram, 2 milligrams may also. But we need something, we need to be on the safe side. There's no side effect. So give at least 100 milligrams if they are in neurobion, or 250 milligrams if they are in Pebrinex, just to be on the safe side, because 1 or 2 milligrams will not work in everybody. In some people, even 1 to 2 milligrams may also work. But we will give at least 100 TDS, which may also prevent progression into largely irreversible Korsakoff psychosis. Now, Korsakoff psychosis is a misnomer. It is not a psychosis. There are no psychotic symptoms. There are more psychotic symptoms in Wernicke's encephalopathy than Korsakoff syndrome, because Wernicke's encephalopathy, in any delirium, you can have the paranoia, you can have auditory, visual hallucinations, tactile hallucinations, olfactory hallucinations. So Korsakoff psychosis, you don't have. You only have one symptom, and that is different kinds of amnesia. So, so that is the prognosis of. So that is a kind of Korsakoff syndrome is a better term, and then prognosis of Korsakoff is large. It is largely irreversible. Once you enter the Korsakoff syndrome, it is largely irreversible. Now I think we'll continue with the Korsakoff syndrome next time. So we'll start from this slide that let's say that the Wernicke's have passed and the patient had been untreated or could not get reversed due to the vitamins we gave, and the patient has got into Korsakoff syndrome or even more severe things, alcoholic dementia, etc. So we'll talk about that in the next sitting, inshallah. Any questions?
No, sir, thank you. It was very informative.
Okay. Yeah. Anybody else? Any questions? Roshan?
It was informative, sir. No questions so far.
Okay. Okay.
सर
Okay.
शुरू में आपने सर एनकेफेलोपैथी और सर शुरू में जो एक आपने बताया था एक कॉज होगी और एक सिम्टम्स होंगे, काइंडली सर वो मिस हो गया, वो एक दफा रिपीट कर दें.
देखिए, encephalopathy is the disease, delirium is a syndrome. So any known cause of delirium which you can clearly pinpoint, and it's usually a single cause, although cause can be more than one, and in many cases there are more than one causes. So that is called encephalopathy. So so hepatic encephalopathy, delirium due to liver, and Wernicke's encephalopathy, delirium due to thiamine deficiency. The 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 drawback of using the term encephalopathy is you can you tend to ignore the other causes. So if you're not ignoring the other causes, then you can use the word encephalopathy, but beware in your mind that there can be other causes at the same time. Patient can present with Wernicke's encephalopathy plus hepatic encephalopathy, और अगर वो इंटॉक्सिकेट हो जाता है तो उसमें इंटॉक्सिकेशन भी ऐड हो जाएगी. तो इसलिए encephalopathy is the disease or the cause, and delirium is the presentation of that disease.
Okay, sir. Thank you.
Okay. All right. So inshallah we'll meet same time next week 10 o'clock.
Thank you very much, sir.
That's the Korsakoff syndrome.
Thank you, sir.
Okay.
Thanks a lot, sir.
Allah.